Hi, everyone, and thank you for joining us today for our webinar on sleep injuries and deaths and what's happening in Maine. Today's webinar is the second out of a series of 4. One was done a few months ago, so this is our second one out of a series of 4 webinars. And today we have Dr. Jennifer Heyman. We also have Kelly Bowden and Dr. Alan Piccarello joining us to provide some information on safe sleep and some updates on the data as well that you all have been providing. So just a few important webinar notes for today before we get into the bulk of the webinar. You are in listen-only mode, so we ask that you use the Q&A function, which is in your toolbar, to ask questions or make comments. We will save time for questions at the end, so definitely feel free to type those in as you have them throughout. Your video screen size and location is adjustable. You just need to kind of click on the video and move it around if it's in the way of your slides. And if you are joining by phone or there's multiple of you at the same computer, we ask that you either type into the chat if you're sharing a computer your name and email address of who's attending, or if you're joining by phone, we ask that you email Morgan after this, or you can email myself and reply to the webinar, whoever that you were on phone, just so we can have that for those records. We do want to thank Hannaford and the Department of Health and Human Services for providing funding and staff time for today's webinar. And just a little bit about Qualidigm. We're hosting this webinar today. We're a mission-driven national healthcare consulting organization. Most of you formerly know us as Maine Quality Counts. We merged with an organization in Connecticut named Qualidigm about 1.5 years ago. We have multiple offices across New England, and we work heavily on projects like this, really focused on quality improvement to drive healthcare improvements. So there is CME being offered for today, and the disclosure is today's speakers do not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. CME is available for participants who have signed into the live webinar. What's going to happen is some of you may already have it in your web browser. A survey actually comes up as you join the webinar, and when you should have like a Survey Monkey maybe showing in your web browser at this point. If you go ahead and complete that Survey Monkey, which is really the evaluation at the end of this webinar, and you ask for CME, we'll compare it with the attendance records from the Ring Central meeting to go ahead and provide access to those CME certificates. If you have trouble getting a CME certificate and you need one, we ask that you please contact Mary. It's MMILAM@qualidigm.org after this webinar, and we can certainly work on helping you get access to your CME certificate. So we have a few speakers with us today. We kind of assembled this all-star team, but Dr. Jennifer Heyman is going to go first in the presentations. Dr. Heyman is a pediatric hospitalist at the Barbara Bush Children's Hospital, where in addition to active inpatient clinical service and resident physician and medical student education, she has an active advocacy interest in preventing unsafe sleep-related infant deaths in Maine. She participates in a statewide multidisciplinary safe sleep task force, as well as the maternal, infant, and fetal mortality review panel, and leads the Barbara Bush Children's Hospital Safety Sleep Committee. She was awarded the Maine Children's Trust Professional Advocate of the Year Award in 2011 for her work in child advocacy and suicide prevention. She also founded the Cribs for Kids Maine chapter to increase access to safe sleep environments to all Maine families. She has provided educational and training sessions statewide on the subject of teaching safe sleep practices to newborn and infant care providers. She has also provided multiple media outlet interviews about the growing concern for sleep-related deaths and has been asked to present at conferences in Maine and nationally on infant safe sleep, including the Council on Injury, Violence, and Poison Prevention, the American Professional Society of the Abuse of Children, Maine chapter of the American Academy of Pediatrics, and Breastfeeding Coalition of New England, and others. In addition to all of that she already does in her advocacy work, Dr. Heyman is active in medical education, medical leadership, and improving hospital safety. She is the director of 4th-year medical student programming at the Barbara Bush Children's Hospital and is a professional coach for medical students from the Tufts University School of Medicine. She has received special citations for her Grand Rounds presentations, as well as Outstanding Pediatrician of the Year award from the Pediatric Residency Program at the Barbara Bush Children's Hospital at Maine Medical Center. And she sits on the board of trustees for Maine Medical Partners. and has publications in various medical journals, as well as many poster and abstract presentations at state and national pediatric medical conferences. We also have Kelly and Alan joining us today. So many of you already know Kelly and Alan. We've worked with them a lot over the past few years on different projects. But Kelly Bowden is the perinatal outreach nurse coordinator for the state of Maine. After graduating from the University of Southern Maine with her bachelor's degree in nursing, she joined the Maine Medical Center NICU staff. Kelly then went on to earn a certificate from Georgetown University as a neonatal nurse practitioner. After working in the NICU for 18 years, she left to become a chart abstractor for the Maine Birth Defects Program and assumed the outreach position in 2004. Kelly completed her master's degree in nursing at USM in 2005, and for the past 10 years, infant safe sleep has been a priority of Kelly's. She has partnered with hospital and community-based providers to assess infant unsafe sleep deaths and to educate those who are working with families on best practices to help eliminate infant unsafe sleep deaths. And then we also have Alan, and Dr. Piccarello is a neonatologist at the Barbara Bush Children's Hospital Level 4 NICU and is involved in the creation, implementation, and data analysis of quality improvement efforts in newborn medicine. He is a member of the neonatal leadership structure for the Northern New England Perinatal Quality Improvement Network, also known as NEPQUIN, and the Maine Perinatal Quality Collaborative in Maine. His areas of expertise and interest include implementation of lean methodology for quality improvement projects, the introduction of quality improvement measures to clinicians and perinatal quality collaboratives. His previous work experience includes co-director for the Massachusetts Neonatal Quality Improvement Collaborative, executive leadership of Virginia Perinatal Quality Collaborative, chief of neonatology at UMass Memorial Healthcare and medical director of Level 3 NICU at Henrico Doctors Hospital in Richmond, Virginia. He also had a corporate position of director of clinical quality for Women's and Children's Service line for Envision Healthcare. In addition, he is national faculty for the Vermont Oxford Network, also known as VAUGN, and has been involved in advocacy at the state and national level for NAS infants. He also has much experience teaching newborn resuscitation, both in the United States and abroad. He's on the AAP steering committee for the Helping Babies Survive program and has introduced and facilitated the instruction of Helping Babies Breathe curriculum to greater than 400 healthcare providers, and has also been involved in teaching newborn medicine topics in resource-poor areas such as Liberia, Haiti, and Ecuador. So as you can see, we have quite the panel for you all today. They'll be sharing different parts of this presentation, but the goals for today is really to review the case examples of sleep-related injuries, as well as review newest death scene review data from the Office of the Chief Medical Examiner. So with that, I am going to turn it over to Dr. Heyman first. She's going to go first with this. And Jen, if you want to go ahead and turn your camera on, and you are off mute, so you should be all good to speak, and I can advance these slides for you as you go.
Great. Thanks, Kayla. Can you hear me before I start?
We can, yes.
Okay, awesome. Thank you for that introduction. I'm sorry that was so long. I'm embarrassed about that intro. I should have provided a cliff notes of that, but we'll get started today. I think a lot of you probably know me, at least by name, or I also spoke at the original kickoff celebration for this program as well. But I'm obviously very involved in safe sleep, and it's a passion project of mine. And how I originally got involved in this was actually not necessarily due to babies dying in unsafe sleep circumstances, but as a pediatric hospitalist where I see patients who are admitted to the hospital, I was noticing that babies were being admitted after injuries. So that's kind of kicked all of this off. And Kelly and I were talking about some other things that this group might find interesting when you're thinking about unsafe sleep in infants. We talk a lot about the babies who die in Maine. And based on how both hospital coding and insurance coding, as well as medical examiner coding goes, we don't have a great idea of really the total denominator of babies dying, particularly, or excuse me, of babies being injured. And this is because a lot of the times when babies are injured in unsafe sleep and get admitted to the hospital, there isn't really a code that says unsafe sleep injury. It may be that they're admitted for a skull fracture, like we're going to talk about today in one of these cases, or something like that. So we do know that there are a lot more kids injured in unsafe sleep circumstances than what we really have a handle on. So we thought it would be helpful today to present a couple of case examples for what's going on in our community. Obviously, I've de-identified these cases. They are cases in Maine, so some of you may feel like, oh, that story sounds familiar to me. If it's a case that you know, obviously we're not going to give any more details than are provided on these slides, and I won't be able to answer many specific questions about them, but I think we'll get a sense of the spectrum of types of circumstances that babies in our community are being injured during unsafe sleep. So the first one that I'll talk about today is a 4-week-old term infant, and this baby fell onto the floor after the parent who was holding the baby fell asleep. Pertinent history for this baby to keep in mind is that the baby was small for gestational age, SGA, and because it was only a 4-week-old baby, a very small baby, that's going to be a baby that's more at risk for getting injured or dying in an unsafe sleep situation because they're not, big enough to respond to a poor situation. Additionally, this baby was diagnosed at birth with neonatal abstinence syndrome, or NAS. As you would expect with that, the maternal care provider was in a medication-assisted treatment program. The mother also endorsed the use of marijuana. And there was, interestingly, in this, in this baby and her parents, a history of intimate partner violence. So when the baby fell, the parents did bring the child in for evaluation because they were concerned. Because of the age and the social circumstances and the baby's history, this child did undergo a full child abuse evaluation. That included a skeletal survey looking for rib or other bony fractures, a CMP looking for injury to the liver or pancreas or other internal organs or signs of bleeding. And then because, as you can imagine, the surface area of a baby's head is the largest amount of surface area. It's the heaviest part of the baby. So when a baby falls, they tend to fall right on their head. So a head CT was performed. And fortunately, this child did not have any intracranial hemorrhaging or bone fractures. Next slide, please. The next case, this is going to sound a little bit familiar, but there's a couple of interesting caveats here. This is a 5-week-old late preterm infant. The mom was feeding the baby in bed, breastfeeding the baby, and fell asleep. The baby fell onto the floor. The partner was in a different room, heard a thud, heard the baby cry, and came and picked up the baby, and mom was still asleep. The partner actually had to wake mom up. She slept through the fall and the ensuing crying. This baby also had a past medical history of NAS. Mom was in an MAT program, and mom also endorsed history of benzodiazepine use. Interestingly, in this baby's newborn nursery course, the meconium and urine were sent for tox screen, and the urine did come back with THC. This baby did receive a DHS referral in the newborn nursery because of co-occurring substance use. And mom had noted that the urine THC was most likely from a tincture of THC tea, so tea that had a tincture of marijuana in it, that she used intermittently in the 3rd trimester for nausea. In the newborn nursery, this mom and the parents had extensive counseling about how to keep the baby safe. Mom also was instructed that if she was going to be breastfeeding, that she should not be using marijuana products, and she agreed to that. There was note in the newborn period that mom was particularly sleepy just around after the baby was born. And so there is documentation that the provider caring for them, as would be typical with a lot of circumstances, recommended that the mom consult her prescribing methadone provider and talk about a back taper now that the baby had been born. So fast forward about 5 weeks later, and this fall happens. This baby was brought immediately to the emergency department. And you can imagine this child also had a child abuse evaluation, which revealed bilateral linear parietal skull fractures and scalp hematomas. There was also a little bit of parietal subarachnoid bleeding around the right side of the parietal skull fracture. And that's not terribly surprising. The mechanism of this injury was likely similar to the first baby, and that rolled off, the head is heavy, hits the ground first, oftentimes will hit sort of at the back of the head, and that transmits forces to the parietal bones, and you can get bilateral fractures that way. And then oftentimes, if there is going to be a little bit of intracranial bleeding, it is along the course of the skull fracture. So this mechanism of injury certainly seemed to be reasonable in terms of what had happened to this baby. Child abuse and DHS were involved in this hospitalization as well, and the baby was ultimately discharged back to her parents. Next slide, please. Now, the other case that I put in here, I wanted to try to draw a contrast. The first two cases, certainly had a lot of psychosocial risk factors in terms of injury for the baby, or potentially falling asleep due to medication needed for substance use disorder. I wanted to draw a contrast so that you have an understanding in the state of what we're seeing for injury. So this is a 6-week-old term baby, so just a little bit older, who presented with not using its right arm, and it was completely limp on exam. The baby was healthy, really had no issues around the time of birth at all. Vaccines were up to date for age. Psychosocially intact parents, no drug, alcohol, tobacco, or other substance use. And there really was no story other than that the baby woke up that morning and was not using its arm at all. So we pursued a stat head and neck MRI and MRA, looking for signs of a stroke, other cerebrovascular concern, or a vessel concern in the neck that could be leading to not using the right arm. And all of that came back negative. And over the 12 hours or so that it took to get that done, the baby wasn't using its arm still, and we were really very perplexed as to what could be going on with this infant, given the unilateral loss of the right arm. It didn't really seem right for most infectious exposures. There was no obvious trauma to the arm, and we really were kind of scratching our heads with the normal head and neck imaging. And so we went back to the history. Obviously, in medicine, we know most of what we need we can find out in our history, right? So we went back to the parents, and one of the parents revealed bed sharing and the morning that the arm went limp, waking up to finding the baby wedged underneath him. So this brought us back to the drawing board, and we thought about that mechanism of injury and what happens when babies get wedged, whether it's between a parent and a mattress, or between couch cushions, or between a wall and the mattress. Is a lot of times the baby will try to move its head to get out of that asphyxial situation. And with that, especially if there's a parent lying partially or completely lying on the baby, the head and neck can get turned and stretched. So we then hypothesized that this baby had a brachial plexus stretch injury. Not a tear or anything, because the MRI was unrevealing. But we suspected, similar as you can see during difficult birth with shoulder dystocia, if you get a stretch in that brachial plexus, you can have some temporary nerve damage. And by the subsequent day, the baby was starting to move its arm again and had was able to fully use the arm in the end. So these are examples of some of the more common injuries that we see. Probably the most common injury that we see that I didn't include in a case just for sake of time today is actually aspiration pneumonia. And every year or two maybe, we'll see a baby that comes in who's been partially asphyxiated or partially suffocated. And what happens when a baby is suffocating, they're obviously working hard to breathe, their diaphragm is moving hard, they're doing everything that they can to move air, and that can lead them to vomit. And if they're working hard to breathe and they vomit, that can lead to aspiration. So we'll have babies come in either with aspiration pneumonitis or aspiration pneumonia, and that's a common injury as well. So that, and then second most common is probably skull fractures or intracranial bleeding after falls from a parent who's fallen asleep, are major injuries that we see. And then sometimes there are more unusual neurologic complications like this. I made sure to pick some cases that, again, showed a wide variety of situations that the babies were in psychosocially. And we're going to talk a little bit more later about some of the risks for unsafe sleep when substances are used in the home. But it's really important to understand that babies both die and are injured when parents are not using substances at all. And I think these cases demonstrate both ends of that curve. Next slide, please. So a couple of take-home messages that I want to make sure people understand, just reviewing these cases before we get into some of the data from the medical examiner's office. And I think the first two cases highlight this very well, which is just a reminder, public service announcement, that a DHHS referral is mandatory in any patient less than 6 months of age or a really non-ambulatory child. So the child could be older than 6 months but has some delays and is non-ambulatory. If they have any sign of trauma, so this is any sort of fracture, any bruising, if they can't cruise, they can't bruise, is something that we talk about, or unusual bleeding, that you need to refer those patients to DHHS. And that's really important because we know a lot of these types of injuries, if this had not been related to bed sharing, and trauma from falling out of the bed, you would worry that these were sentinel injuries from abuse, and that's a very high risk situation for that child. So just always remember, and I would say even if you have a baby who you feel like is injured in an unsafe sleep environment, you always need to think about, could this be non-accidental trauma? A couple other things to keep in mind, and my next slide, which I'm not ready for yet, but it's going to talk a little bit about why or how babies are at increased risk of dying if they are in an unsafe sleep situation with parents who use substances. So it's important to keep in mind, if you looking at a child as an individual, if that child has parents who use substances, they are more likely to die while bed sharing or couch sharing, etc., than a baby who is in a situation where the parents are not using substances. So those babies are particularly high risk. That said, it's important to remember in Maine that depending on the year, it's about half of babies who die in Maine in unsafe sleep circumstances do not have parents who use drugs or alcohol. So sometimes this feels a little bit like an oxymoron or kind of doesn't make sense. But I think if you think of it as, yes, a child is more likely to die if the parents are under the influences of substances, that makes sense intuitively, but understanding that those are not the only babies at risk. Any baby who's in an unsafe sleep situation, even if the parents are not using substances, can die. And in Maine, that's about 50% of our population of babies who die in unsafe sleep. Next slide, please. So here's just one little study that has nice kind of easy math that I thought I would share with you. There are a lot of studies that look at the risk of unsafe sleep alone and the risk of unsafe sleep with a parent who is under the influence of drugs or alcohol. I like this study, even though it's a little bit old. It's by a person who actually does a lot of research into sleep-related deaths. And this looked specifically at bed sharing, and found that there was an odds ratio of around 5. So this means you're about 5 times more likely as a baby to die while bed sharing than if you were in your own crib or bassinet. Now, if you combined bed sharing with parents who use drugs or alcohol, that odds ratio went up 10 times to 53. So that those babies who are bed sharing with a parent who is under the influence are 53 times more likely to die while asleep. In terms of odds ratios of risk of dying while bed sharing, you can find odds ratios anywhere from 4 to 90 to 100. There's a large variability in terms of the risk of bed sharing. But the point of this study is really to point out that there's a good risk of just bed sharing alone, 5 times more likely to die. But it's important to keep in mind that that risk goes up tenfold when parents are using drugs or alcohol. And that's what makes these babies a little bit more high risk, or quite a bit more high risk. And I think that this makes sense because if you have a parent who is potentially impaired, they can't respond to a baby who's an extremist. Another important point to keep in mind with this study in particular, when I first read this, I thought, okay, well, these parents must be very inebriated, and not kind of responsive at all. The study design for this was looking at parents who had consumed the equivalent of only 1 to 2 beers. So this wasn't, like there was a lot of alcohol or drugs on board. And the other thing to keep in mind here, when we think about drug use, we usually think about inappropriate use of prescription drugs or street drugs. But keep in mind that over-the-counter cold preparations like Benadryl, those obviously alter parents' abilities to respond, and the likelihood of injuring a baby during unsafe sleep goes up even with over-the-counter drugs being used appropriately. Next slide, please. So that brings us to talking a little bit about what we're seeing at the Office of the Chief Medical Examiner. Kelly and I and some other folks around the state for years now have been lucky enough to partner with the Chief Medical Examiner's office to go and look at the case files of babies that die unexpectedly. Obviously, when a baby dies, that's filed in a computer, and the state gets the data around a baby who has died. And depending on how that death is coded, at the state level, we're able to get a sense for how many babies die each year in Maine. But what we don't get a sense of is what are those safe sleep environment, or what are those sleep environments really looking like? So we go to the medical examiner's office and they provide us with the case files, which contain death certificates, autopsy results, and importantly, a death scene investigation that ideally is done in a very structured manner with a structured form with police who are trained to look at an environment, and we can pull out if there were risk factors for that baby's death. So I'm going to go through a couple different cohorts of babies here, and you'll see some themes emerging. So 2002 to 2006, we just kind of use this as more baseline data. You can see here that the mean age is around 3.5 months, and that's important. You'll see this kind of 3 to 3.5 months is a common average age. And that's important because that's also right around where SIDS peaks, sudden infant death syndrome. So I think a long time ago, there was some confusion as to about babies dying during sleep. It was just SIDS. We didn't have an explanation for it. But now we do much more scene investigation and can understand the role of unsafe sleep in that. 56% of babies who died were bed sharing at the time of death, and 2/3 of the babies were not on their back to sleep, were not on the proper sleep surface, meaning they weren't in a crib or bassinet or with a firm mattress, and they had too much stuff in their crib environment. 94% of the babies who died were unsafe, and only 3 of them met the criteria that the AAP sets forth for safe sleep. Now, some of you might be saying, well, of course, these are babies who unexpectedly died during sleep. You would assume that they were in an unsafe sleep environment. But I think, we didn't know that until we started looking at things. And this by no means allows us to connect causality of unsafe sleep to that child's death. That we can't do that with this, but it certainly brings up the concern for the risks in the environment. From 2009 to 14, there were 77 deaths. About half were bed sharing. Only 44% were back to sleep. This is important to look at, and you'll see this number throughout the rest of the cohorts as well. In the 1990s, the Back to Sleep campaign was probably the most successful public health campaign decreasing infant death that we've ever seen in this country. And at one point, we had 85 or 90% of the babies in this country sleeping on their backs. And I'll point out only 44% on their backs in this cohort. 3/4 had unsafe items in their sleep environment. 5 of them were using a boppy pillow. The baby was placed in the boppy pillow, either in the crib or on a couch. And that is a particularly dangerous setup for a baby, especially a younger baby, because when they're put in that round circular boppy pillow with the hole in the middle where the butt fits in quite nicely, they fit in quite nicely for a few minutes, but baby's tone tends to be pretty low, and they can sort of fall down and scooch down and either asphyxiate on the pillow, or their head gets pushed forward and they can't pick it up, and they asphyxiate that way. 55% were environmental tobacco smoke exposed. Kelly's going to talk to you about the importance of tobacco smoke when it comes to sudden unexpected infant death. So just be paying attention in Maine to how many of these babies who die have environmental tobacco smoke at home. Overall, 19% were diagnosed with NAS. This peaked in 2012 with 47%. And the next year, it dropped to an all-time low of 14%. I did want to point out that about half of those babies who were bed sharing had parents who used substances. So that puts us back, a reminder for the last study, last slide, that we know that parents who use substances and bed share, those babies are at higher risk of dying. Overall, 45% of these babies were substance exposed. So again, that means they had parents or had a mother who used substances during pregnancy, but maybe did not necessarily meet the criteria for NAS. One thing to keep in mind here, we saw a newer risk factor. We had started talking about the importance of using wearable blankets, which provides a safer way to swaddle a baby. These are fantastic, and we 100% support the use of them. But if you use them incorrectly, just like with anything, they can cause harm. And there were 2 babies in this cohort who were well over 2 to 3 months of age, who had been swaddled with their arms in. So arms in, and the wings of the swaddler kept them in, and those babies had rolled over onto their stomachs. Their face was trapped into the mattress, and they couldn't use their arms to push up and move their head. So that just helped us think a little bit about how we get the message out about safely wearing, using wearable blankets. Next slide. 2015 to 2017, age range here about 3 months, males 75% of the time. What we found interesting here, and what's important to keep an eye out for, is that we started to see a resurgence of babies dying while sofa sharing. 9% in this cohort. We know that sleeping on a sofa, either the baby alone sleeping on the sofa or sleeping with another human being on the sofa, is probably the least safe location for the baby to sleep because of all the cushions and things like that. Almost 80% were bed sharing. Again, we're around only half, 53% back to sleep. This time they had an NAS diagnosis about a quarter of the time, but they were substance exposed about half the time. And 56% of them were exposed to environmental tobacco smoke. And here we had 1 baby die in a boppy. And then that brings us to 2018-19, where there were 21 deaths. That did not make it onto the slide. And interestingly, the average age of this has gone up a little bit to almost 4 months. And this is despite actually taking some outliers out of there when you have a small cohort. And if you have a couple of outliers, obviously it can move that number. But even throwing those out, the average age seems just a little bit older. 52% were female, sofa sleeping now in 21%, bed sharing 62% of the time. Back to sleep, this has been an all-time low now of only 33%. And when we look at the PRAMS data, which Kelly's going to talk a little bit about, but the Pregnancy Risk Assessment Monitoring System data for Maine, a much higher percentage of people note that they usually or always put their baby to sleep on their back, and usually or always put their baby to sleep in a crib or a bassinet. So these numbers that we're seeing in the babies who die in Maine are much different than what we see are reported to PRAMS. So this again is just, I think, a link showing us that these unsafe sleep risk variables are potentially contributing to infant death. NAS diagnosis in 14% of babies here, but exposure was still right around 52%. Alan probably can speak a little bit better to this to me, but when I see the NAS diagnosis dropping off here, I think that that may in part have to do with the fact that we are moving more towards an eat, sleep, console protocol, fewer babies getting medications, and I'm not sure if that's actually decreasing the official diagnosis of NAS being given or not, but this was a low kind of cohort. Again, about half environmental tobacco smoke exposed, and a BOPI present at the time of death one time again. Next slide, please. I wanted to then kind of compare for you how these deaths are coded by the medical examiner. So there's a lot of different codes the medical examiner can use, obviously. When we first looked at this, and I didn't put all the cohorts up here for you, but just to get a sense for trend. But in 2009 to 2011, SUID, or sudden unexpected infant death, was the final cause of death 56% of the time, undetermined 18%, and asphyxial death only 15%, and SIDS 12%. And these numbers had shifted even a little bit from when we kind of got our baseline denominators from 2002 to 2006, where we saw less reliance on SIDS as a diagnosis and the SUID diagnosis growing. And that's important because over the last decade or so, in the ME world and people who do public health and child trauma have come to the consensus that SIDS, that diagnosis, should really be retained for when we really have no explanation at all for why a baby died. And if a baby was in an unsafe sleep circumstance, that could contribute to the death, and that should not be an idiopathic or a SIDS death. But those then get coded either as SUIDs or asphyxia if there's a lot of evidence that that is why the baby died. So go forward to 2012 to 2014, you can see here SUID, the percentage of that has dropped quite a bit, and asphyxia has come up. 14% still were labeled SIDS, but 3/4 of those babies, when we did the case reviews, were bed sharing at the time of death. So really, truly, those should not be SIDS deaths. And undetermined, 7%, and half of those were also bed sharing at the time of death. So that might make you think a little bit more about a SUID type of death. And then what really struck me, Kelly and I just fairly recently went to the ME's office and looked at the 2018-19 charts, and I just kind of reviewed the data, and 100% of the deaths were coded as asphyxia this time. There are different ways to code asphyxia. There could be asphyxia with markedly suboptimal sleep circumstances in place, asphyxia with obvious entrapment. There's different ways that this is described on the death certificates, but 100% of them were coded as asphyxia. And so what that tells us, I started out kind of talking about this, saying with us going to the ME's office and finding that these babies who are dying unexpectedly are in unsafe sleep environments, that we can't 100% say that's what caused that baby to die. It has been interesting as the medical community has gotten more information and a better understanding on this, to see the change in how the medical examiners, who are the experts obviously in causes of death, have changed how they look at this. And now they really are much more willing to call something asphyxia if the data is there to show that. So we're not really seeing any more SIDS in these babies who die unexpectedly. Next slide. I'll take it over to Kelly.
Great, thanks, Jen. So last year, and some of you have heard me talk about this already, so but it just important to highlight again that in pediatrics last April, there was a study presented that looked at sudden unexplained infant deaths and maternal smoking during pregnancy. And their assessment was that of those sudden unexplained infant deaths, somewhere between 20 and 25% of those deaths could be attributed to smoking during pregnancy. And in prior years, we've had always thought that it was the smoking after pregnancy, that it was secondhand smoke or the third-hand smoke on people's clothes. And so this was really the first time someone had documented that it was actually the smoking during pregnancy And the theory is that the smoking during pregnancy changes some of the chemical receptors in the fetal brain and makes them less responsive to hypoxia and more susceptible to sudden unexplained infant death. And then the chart there that you see is some of our PRAMS data about cigarette smoking rates. So you can see on the far right-hand side, comparing to 34 sites across the country. So most states do have a PRAMS project in their state. And when they looked at those 34 states, women who smoked during the 3 months before pregnancy was around 19%. In the last 3 months of pregnancy was around 9%, and smoking after delivery was around 12.5%. So that was from 2015, and you compare Maine in 2015, much higher rates of smoking before pregnancy, during, and after pregnancy. You can go to the next slide, please. And then if we look at the category of smoking among women of childbearing age, so these aren't pregnant women specifically, just women of childbearing age, which is considered 18 to 44. We had a huge spike in 2011. Almost 30% of women of childbearing age were smoking at that point. But our average still hovers around 20% of women of childbearing age in Maine are smoking. And so just a reminder to refer people to resources. It's a challenging conversation. It just certainly ties into our high rates of opiate addiction. We know that many of the moms who are opiate dependent are also smoking cigarettes. So the emerging research is that when people quit both substances at the same time, they're much more successful in their quit attempt and their recovery process. So if you're working with a mom who is in MAT, it's really okay to talk to her about cutting back or quitting her smoking. You can go to the next slide, please. And I just want to remind people about these great resources that are available in the Maine Prevention Store. These are available at no cost. There may be some shipping costs associated. There's rec cards, the Safe Sleep for Me and the ABCs alone on their back and in a clean, clear crib. There's window clings and magnets, and then there's the board book, Sleep Baby, Safe and Snug. Really excellent board book, and the evidence is showing us that when families read that board book, their integration of what they read in the board book into practice is higher than when they have other materials such as the NIH materials on safe sleep. So it may seem strange or weird to use a board book for teaching for adults, but the research is showing us, at least initially, that it's quite effective. So I'm going to turn it back to Jen to summarize.
There we go. Great. So just for some take-home points when we think about the data from the ME's office as well as the cases that I talked about, we know just based on the physiological development of babies that when they're less than 3 months of age, that's when they're the highest risk for dying in an unsafe sleep environment. But there's a few very young babies who die before the first checkup. And so one of the things we need to remember is that we can't wait to talk about safe sleep at the first weight check or vaccine visit. This really needs to be done in the newborn nursery and ideally prenatally. Over half of the babies who die in Maine had in utero second or third hand tobacco smoke exposure. And this could have grave implications on why babies are dying. About half of the babies who die during sleep in Maine are not substance exposed and do not have a diagnosis of NAS. We have seen the percentage of babies whose guardians use substances rise over the last decade. And the PRAMS data in Maine says that 9 out of 10 times babies are usually, I think it's always or usually, placed in sleep in a crib or bassinet. But our death scene review shows a very different picture. And so that, again, is just something to keep in mind, that we know that when babies are not placed safely, they are more at risk of dying.
All right. So I guess this looks like one of my slides. So as part of the project across the state, we wanted to make sure we collected data like any type of quality improvement project. If you can measure it, it's very hard to improve it. So we wanted to look specifically at what are we doing for safe sleep in the state, in the inpatient setting and also the outpatient setting. And I'll talk about that in a little bit. So as part of our meeting that was supported by the March of Dimes back in October, we agreed that we'd be doing monthly audits. So once a month, all the participating hospitals look at their infants, so age of 1 and under 1 year of age, who are hospitalized and who meet criteria for safe sleep. By using the Cribs for Kids audit, we'd see how compliant are we with actual safe sleep and what we're demonstrating to the families. So what I want to show is in February, March, and April, these were done at the beginning of each of the months. We had about the same number of hospitals participated, actually sent data in. Now the numbers of hospitals that actually higher that are participating, but what we found was up to a quarter of the hospitals on any given day actually did not have any patients in the hospital itself. The number of audits you can see are in orange. They from a high of 107 in February down to about 70 in April, which I really want to be thankful for all those folks, especially who submitted their data in April. It's always nice to see some non-COVID data coming in. So I really appreciate everyone working hard and getting that done. The April numbers are actually a little slightly higher than what you see there. One of the hospitals, we just had a couple data questions, so I could not add them into the final number. And also, I did mention the outpatient. Public health nursing has really stepped up and done an amazing amount of in-home observations for safe sleep. And to me, that's really the holy grail. If we're looking what we demonstrate in the hospital, I think that's wonderful, but it's so nice how that translates at home. And I really appreciate public health nursing contributing some of the data. So you'll see them in subsequent months added to our data itself. Next slide. So this is literally the data hot off the press with, again, not including one hospital in the public health nursing as of this past month. This is the Cribs for Kids audit. You can see there are 3, 6, 8 different pieces that we audit. One is not on here, that is swaddling. I did not include that on the data presentations. What I want to show is, again, for the most part, the data either got better or stayed the same from February through April. So all the February data is in blue, the March data is in orange, and the April data is in gray, again, on these bar graphs. And each individual cluster of 3 corresponds to a question on the Cribs for Kids audit data. All the way to the end is the overall compliance. And so what that last one means is what % of babies basically passed every single audit question. Next slide. I do want to just hover on this one. This is where it seemed to have the most gain. So this is babies who have multiple blankets in the crib. So either under the baby, so a burp cloth that is not tucked in under the mattress, or just blankets sitting in the crib itself. And as you can see, our baseline in February, we were at about 70%, and then it has gone up to about 85%. If we look at the overall compliance, next slide. This is the increase we've seen. So again, specifically, what % of babies basically passed their audit? So we started off at about 57.5% in February. In March, that number went up to 68.7%. And then in April, we're up over 75%, although that number will increase even higher as we add in the additional hospital. So this is really, really great news. I really hope we can get to at least 90%. Actually, frankly, we should hopefully be hitting 100%. But I'm anticipating we should hopefully hit in the 90% on the overall compliance with the audit by the middle of the summer. Again, this is really great work. This shows that we're demonstrating to families what is safe sleep right in front of them. So we're not just having them watch videos or read a book. about safe sleep, and we're actually showing them what safe sleep is. So again, I really appreciate all the work that's gone in from all the bedside providers at each of the individual hospitals, all the work providing education to the families and all the people who frankly are doing the audits, so we can show that there has been an increase with this initiative across the state. So thank you all very much.
Great, thank you all. So we do have time for some questions if people want to type their questions into the Q&A. You can ask questions about the data or some of the cases that Dr. Heyman or Kelly shared. So go ahead and type into the Q&A feature if you have any questions. You can also use the chat. So we do have a few questions in the chat. Do you know if the rate increased with the number increase? I'm not sure if someone could clarify that a little bit more. I'm not sure exactly.
Yeah, so I think the question is about percent of infants who were injured due to unsafe sleep. And I don't know if Jen is able to unmute and speak to that. Yes, great. Go ahead, Jen.
Yeah, I was just looking at that to make sure I understood. If the question is around how many babies in the state of Maine are injured in unsafe sleep, we don't really know that data at all. And I didn't mention this, but in part, most babies who are injured in unsafe sleep don't actually report for medical care, so it's very underreported. If the question was about, has there been an increase in the numbers of babies dying, how I present the data is a little bit confusing because sometimes we do 2 years at a time, sometimes 3 years at a time. So it can sort of look like the numbers are going up and down. In general, about 10 to 12, sometimes up to 15 babies will die in unsafe sleep circumstances in Maine each year. We had a peak in, I think it was 2013, Kelly, is that right? Where there was maybe 16 or 17, something like that. But in general, it's fairly constant between 10 and 12. I'm not sure if that answered that, so maybe type back.
So another question is, did the smoking information include vaping?
It did not. This was pure cigarette smoking. Vaping is an emerging issue that we're monitoring and trying to collect more data about.
Great. So another question, how do you prevent babies from rolling on their stomachs once they are able to roll? I've seen some babies be able to roll over things wedged against them to keep them on their backs.
Yeah, I can take that one. That's a great question. And once babies can roll, we shouldn't be fighting with them not to roll. That's developmentally appropriate. So that's when babies can start to roll, sometimes it's 2 months, it's 3 months. That's when we worry a little bit less about entrapment and things like that. Because once they have the neurologic strength to do that, if they get themselves on their belly, they can use their arms, they can push up and turn their head to the side. What we don't want to do is use wedge or other types of positioners to keep babies on their backs. We see people doing that, and it makes sense because we know back is best to sleep. But those positioners actually can end up asphyxiating babies, and they do more harm than good. So once the baby can roll, you can worry a little bit less about that, and there's really no need to, you should put the baby to sleep on its back to start, but if it flips itself over in the middle of the night, that's okay.
And I'll just add to that those devices and positioners that are marketed as prevents SIDS, many of them have not been tested through the Consumer Product Safety Commission. They are labeled as a SIDS preventing tool, and there is no evidence to support that marketing claim.
We have time for 1 or 2 more questions. If people still have some, you can put them into chat. But Kelly and Alan, I know this is something that comes up a lot, so I'll go ahead and ask it. Kind of the stance around breastfeeding and the safe sleep. And I know there's been a lot back and forth on this. If you all just want to contribute a little bit more information on that piece.
Kelly, I'm going to let you go first on this one.
Yeah, so that's one of the things when Dr. Heyman and I are out teaching, we are 1,000% supportive of breastfeeding, and we know that there's many wonderful things about breastfeeding and boosting the immune system and the bonding and the parent interaction. But as you saw in the data, that of the babies who die each year, at least half of them were bed sharing. And so there is no evidence of how to safely bed share. And so our recommendation is we want moms to breastfeed. And then when they're done breastfeeding, if they're sleepy, put the baby in a bassinet or other safe sleep space next to the adult bed space.
Yeah, I agree. I think it's so difficult because I know we want to clearly balance the best nutrition for the infant, but also with some safety that has to be paramount, and some type of safety guardrail has to be part of this.
Great, thank you both for that. I know that can be a topic that comes up a lot. One other question is, curious if anyone has looked at the use of wood stoves in the home as a risk factor.
We have not captured that when we've been doing the chart abstraction at the medical examiner's office. I'm not sure that that's always documented. And if someone's really curious and want to see what the state police capture, if you go to the federal CDC website, cdc.gov, and you type in SUID, S-U-I-D, and it's the Sudden Unexpected Infant Death Investigation Form. The state police do an amazing job of collecting data like the temperature in the room where the baby passed. They offer families a doll reenactment to show how the baby was placed for sleep, how the baby was found, and if anyone had checked on the baby during that sleep cycle. So there's a great deal of information, but I don't remember if wood stove is one of the, and Jen, do you remember?
Yeah, no, that's not one of the things that we look at. And I think that's a really interesting concept when we think about environmental safety. One thing to keep in mind that, there's a million substances in tobacco smoke. Obviously, the most well-studied is going to be nicotine. And part of the reason that the CDC, Kelly mentioned that 22 to 25% of SUID deaths may be preventable if we avoid tobacco smoke during pregnancy. The most well-studied or thought out part of that is specifically around the nicotine component to that and what it does to the immature nervous system of a fetus in utero and then a baby, and making that baby less able to respond to an untoward circumstance. So the nicotine piece obviously is going to be a little bit different than, with fire burning.
Great, well, thank you. I want to thank you all for joining us today. We're almost at the end of the hour, so I want to thank you, Alan, Jennifer, and Kelly for joining us today for this webinar and sharing the information. We do have a few more webinars coming up. We have one in June and one in August. So after today's webinar, we'll be sending out kind of the follow-up information. And with that, you will receive the dates, so you can go ahead and save the dates on your calendar for those next two webinars. And again, if you had any information or any trouble with getting the evaluation after the fact, we're going to put the link in the chat box for people to use. But if you have problems getting to the evaluation after the fact, you can certainly contact myself, Mary, or Morgan. All of our information is on this screen, and we can help get that information over to you. But again, we just thank everyone for joining us today. We hope you enjoy the rest of your afternoons, and stay safe, everyone.
And Kayla, one last thing. The next Safe Sleep audit is going to be a week from today, and Kelly will send out a reminder email, but for just people to mark it on your calendar, May 5th will be the next audit.
Great. Well, thank you, everyone. I hope you have a great afternoon.